Hello everyone. As a continuation of the ECG lecture series, in this session we will be discussing the ST segment, that is the abnormalities of the ST segment. So if you take this ST segment it is a flat isoelectric section of the ECG and where it starts from. And always remember, segment in the ECG, it means it includes only an isoelectric baseline. Whereas if you take interval, it includes the isoelectric baseline and as well as a wave. But whereas if you are seeing the word ST segment, it is between the end of the S wave and the beginning of the T wave. So this is what is called as the ST segment, which is so if you see this particular ST segment, it represents the interval between the ventricular depolarization. So this is your ventricular depolarization and the ventricular repolarization. So that is what is your ST segment. So it represents the interval between the ventricular depolarization and ventricular repolarization. Now, if you take the abnormalities of the ST segment, the abnormalities include certain clinical conditions. You have the ST segment elevation, and in certain clinical conditions you have the ST segment depression. Now, let me first discuss what is the criteria to call it as abnormal in the ST segment elevation. So, if you see this question here, how much should be the minimum ST elevation in the limb leads for considering myocardial infarction? Right? What should be the minimum ST segment elevation in the limb leads for considering myocardial infarction? More than 2 mm, more than 1 mm, less than 1 mm, more than 1.5 mm. See, the question is on the limb leads. Now, the answer to this question is it should be more than 1 mm in the limb leads to consider it as MI. And this particular more than 1 mm should be in the contiguous leads. Then only we call it as the myocardial infarction. Now, following that, what is the criteria to call myocardial infarction in the precordial leads? What should be the minimum ST segment elevation in the precordial leads? So, if you take in the precordial leads, age of the individual less than 40 years, it should be minimum more than 2.5 mm. Age of the individual more than 40 years, it should be more than 2 mm. Right? It should be more than 2 mm. So that is a criteria to call it as the ST segment elevation in the precordial leads, that is the chest leads. Whereas you take in the limb leads and as well as the augmented leads. So limb leads in the sense L1, L2, L3 and augmented leads, that is AVR, AVL and as well as AVF. So all other leads, if the ST segment elevation, if it is more than 1 mm, we can consider it as the myocardial infarction. But remember, this ST segment elevation should be more than 1 mm in minimum of the 2 contiguous leads, right? So that is very, very important point. Okay, so this is a criteria to call it as myocardial infarction depending upon your ST segment elevation. Now, ST segment elevation, it doesn't just mean only myocardial infarction. There are many clinical conditions where you have the ST segment elevation. Now let me show you a ECG and as well as the conditions where you have the ST segment elevation. So you see this question. So the question is, ST elevation is seen in all of the following conditions except myocardial infarction, coronary artery spasm, constrictive pericarditis, ventricular aneurysm. So I am not correlating these options with the ECG what I have shown you. I am just asking you what are the clinical conditions you will have ST segment elevation, but the question asked here is except. That means in which of the following conditions you don't have ST segment elevation, right? That is what is the question. So the answer here is the constrictive pericarditis, right? The answer here is the constrictive pericarditis. Whereas you take the other options like myocardial infarction, coronary artery spasm, ventricular aneurysm, in all the other conditions you have the ST segment elevation. I will show you the respective ECGs as well. But before going on to further discussion, first let me tell you all the conditions wherever you have the ST segment elevation. Now I'll just tell you all the conditions causing ST segment elevation with the help of a mnemonic, and that particular mnemonic is elevation. So out of this you take the word E. It stands for electrolyte disturbances. And this particular electrolyte disturbance, it includes hyperkalemia. So in hyperkalemia, you have the ST segment elevation. And the word L stands for left bundle branch block. The word E is early repolarization variant. That is benign early repolarization. Next, you take the word V, stands for ventricular aneurysm. And you take the word T, stands for trauma. So which particular trauma? Like in a patient with the cardiac tamponade, you have done pericardiocentesis. So this pericardiocentesis, it is a life-saving procedure in a case of the cardiac tamponade. Next, the word I is ischemia, that is myocardial ischemia, or that is nothing but your ischemic injury, myocardial infarction. The word O stands for the Osborn wave. And this particular Osborn wave you will see in hypothermia. And the word N stands for non-occlusive vasospasm. And this non-occlusive vasospasm, where do you have this? You will have this in case of Printzmetal angina. Right, in a clinical scenario of Printzmetal angina. And the word A stands for acute pericarditis. And the word B stands for Brugada Syndrome. So these are all the clinical conditions where you will have the ST segment elevation. Right, now I will show you all these ECGs with the help of a clinical scenarios. Okay, now you see the first question. So in this question you see we have a 70-year male who is a known case of diabetic and as well as CKD stage 5. He presented with history of dyspnea and ECG shows is as follows. And what is the diagnosis? So the history is very important to us, that the individual is at CKD stage 5. Okay, that is end stage renal failure. So in end stage renal failure, what are the electrolyte abnormalities you can have? One among that is your hyperkalemia. Right, there are many other electrolyte abnormalities, but one among that is your hyperkalemia. Now in case of hyperkalemia, like what will be the ECG changes? So you can see that there is presence of tall tented T waves. Right, there is presence of tall tented T waves. And the other important point is, in patients with hyperkalemia, you also have the ST segment elevation. So you can make out here that is presence of the ST segment elevation. Okay, so in the mnemonic, the first letter in the mnemonic was electrolyte abnormalities. And which electrolyte abnormalities you will have this ST segment elevation? That is in case of the hyperkalemia. Now at this juncture, like let me discuss what will be the ECG changes, all other ECG changes in both hyperkalemia and as well as the hypokalemia. One we have discussed, that is ST segment elevation. Now what are the other ECG changes in both hypo and as well as hyper? Let me complete at this juncture itself. So the next question is, so the answer in this is hyperkalemia. The next question is, which among the following is not the ECG findings in hypokalemia? You see that question, hypokalemia. Short PR interval, T wave flattening and inversion, ST depression, the prominent U wave. Now, one important point that you need to know is in the abnormalities of the ST segment, in hyperkalemia, you have ST segment elevation, whereas in hypokalemia, you have the ST segment depression. So, ST segment depression can be seen in patients with the hypokalemia. And in hypokalemia, the earliest change is the flattening of the T wave. And there is also development of the U wave after the flattening of the T wave. So that is what is your hypokalemia ECG changes. But remember, in hypokalemia, there will be prolongation of the PR interval. Short PR interval will not be seen in patients with the hypokalemia. So to summarize all the changes in one slide related to your hypokalemia, this is the following. So remember, the normal potassium value is around 3.5 to 5 milliequivalents per liter. That is the normal potassium value. Now, when does this particular ECG changes appear is, the ECG changes appear mainly when the potassium levels are less than 2.7 milliequivalents per liter. Most of the time, it can appear even at the level of 3 millimoles per liter. But what I am saying is, most of the time, the ECG changes will appear when the potassium levels are less than 2.7 millimoles per liter. Now, what is the earliest change I have said you? The earliest change is the T wave flattening or the T wave inversion. And after the T wave flattening or inversion, the next is the prominence of the U wave, right? I'll show you all that particular ECG changes, okay, in a ECG. And if you see the appearance of the U wave, now if you take the QT interval, now you will not have QT interval anymore because the T wave is flattened or inverted. So what we calculate is QU interval, right? What we calculate is the QU interval, and this particular QU interval is increased or it is prolonged. And not only QU interval, even PR interval is also prolonged, right? And ST segment will be depressed. And what will happen to your P wave? Remember, these individuals with hypokalemia, they have what is called pseudo P pulmonale. Right, they have what is called pseudo P pulmonale. So pseudo P pulmonale is increase in the amplitude of the P wave. Right, so the same point I have discussed when I was discussing the abnormalities of the P wave also. So where the amplitude of the P wave will be more than 2.5 mm in the limb leads. Right, more than 2.5 mm in the limb leads. Okay, so there will be increase in the amplitude of the P wave. So these are the ECG changes like what you will have in hypokalemia. The earliest change, the flattening of the T wave or T wave inversion. Second important, appearance of the U wave. Then long QU interval, prolonged PR interval, ST segment depression, and then the appearance of the pseudo P pulmonale. The amplitude of the P wave increases. And why do we use this word pseudo? Why? Because actually you will have P pulmonale in patients with a right atrial hypertrophy secondary to tricuspid stenosis or secondary to pulmonary stenosis or secondary to pulmonary hypertension. But in these patients with the hypokalemia, in the absence of the right atrial hypertrophy, the individual is having the increase in the amplitude of the P wave, and that is the reason why it is called as pseudo P pulmonale. Now you see one ECG also related to your hypokalemia. So why are we discussing hypokalemia in the abnormalities of the ST segment? Why? Because in hypokalemia you have ST segment depression. In hyperkalemia you have ST segment elevation. So that is why we are discussing the hypokalemia related to your abnormalities of the ST segment. So if you take this particular ECG here, what is that you are able to make out? The T wave, it is inverted. right? And there is appearance of the U wave, right? There is appearance of the U wave. And the next important thing is, if you take the QU interval, right? The QU interval, it is prolonged, right? There is long QU interval. And then followed by that, if you take the ST segment, right? ST segment, it is depressed. And if you take the P wave, right? This is not shown here in this ECG, but you can have the presence of the pseudo P pulmonale. In this ECG, related to hypokalemia, the changes what you have is T wave inversion, prominent U wave, long QU interval, and as well as the ST segment depression. So these are the ECG changes of hypokalemia that can be seen in this particular ECG. Now, followed by that, you take hyperkalemia. In hyperkalemia, what did I discuss? That you will have the presence of ST segment elevation. Now, in case of the hyperkalemia, the earliest change will be appearance of tall tented T waves, right? Appearance of tall tented T waves. Now, what will be the effect of hyperkalemia on the heart? The effect of hyperkalemia on the heart is that in hyperkalemia, now what is happening? The extracellular potassium is increasing. Now the extracellular potassium will become more than 5.5 milliequivalents per liter. Now once the extracellular potassium is increased, that will reduce the myocardial excitability, right? That will reduce the myocardial excitability. Okay, so once there is reduction of the myocardial excitability, why is that due to? That is due to reduced conduction through the conducting system of the heart, right? And the other point is, progressively worsening hyperkalemia leads to suppression of the impulse generation by the SA node. So SA node impulse generation will be completely suppressed, and there will be reduced conduction even at the level of the AV node, right? There will be reduced conduction even at the level of the AV node and his Purkinje system. So what is the basic effect of hyperkalemia now? Reduced myocardial excitability, reduced impulse generation at the SA node, and reduced conduction at the level of the AV node and as well as the his Purkinje system. Now what will be the resultant effect? The resultant effect can be bradycardia because of reduced depolarization of the SA node. There can be conduction block because of reduced conduction through the AV node, and ultimately the individual will have bradyarrhythmias and finally arrest. Now let me discuss what are all the other ECG changes in hyperkalemia. So you see this question, which among the following is not the ECG findings of the hyperkalemia? The P wave widens and flattens, PR segment lengthens, the P wave disappears, narrow QRS complex. The answer in this question is the narrow QRS complex. Remember, in patients with hyperkalemia, you will have the presence of, right? You will have the presence of wide QRS complex, right? You will have the presence of the wide QRS complex. You will not have the narrow QRS complex. Okay. Now, the next important point is, what are all the other ECG changes in hyperkalemia, right? Let me discuss the ECG changes, and I will also show you the respective ECGs with that ECG changes related to your hyperkalemia. So when do we use the word hyperkalemia? When do we use the word hyperkalemia? When the potassium levels are more than 5.5 milliequivalents per liter, that is what is called as the hyperkalemia. And more than 6, it is called moderate hyperkalemia. More than 7, it is called severe hyperkalemia. And when the serum potassium levels are more than 5.5 milliequivalents per liter, that is associated with the repolarization abnormalities, right? That is associated with the repolarization abnormalities when the potassium levels are more than 5.5. Now, in a sequence, let me tell you what will be the ECG changes. Then I will show you the respective ECGs also. So you take this particular ECG changes This is a normal PQRST complex when the potassium levels are normal. But when the potassium levels are gradually increasing, what is the first change? Appearance of tall tented T waves. Right? Appearance of tall tented T waves. Then the other changes are, there will be also abnormality in the PR segment. So if you take this PR segment, there will be lengthening of the PR segment. And you take the ST segment. ST segment, it becomes elevated. So the ST segment is pulled upwards along with this particular tall T wave. And these individuals, at one point of time, the P wave, it becomes flat. And see, this is your P wave becoming flat. And the other thing is, if you take the QRS complex, it becomes wide. This is called as the sine wave pattern. So this is nothing but your mathematical sine wave. Right? This is nothing but your mathematical sine wave. Okay. So these are the ECG changes like what you will have in patients with the hyperkalemia. So number one, appearance of tall tented T waves. Number two, the widening of the PR segment. 3, ST segment elevation. 4, flattening of the P wave. 5, like wide QRS complex and complete disappearance of your P wave. And that is nothing but your, so this particular QRS complex with the absent P wave, it is appearing like a mathematical sine. So this is called as mathematical sine wave. Now let me show you the respective ECGs also. Right? You see here, this is the ECG with tall tented T waves. And I'll show you the Ecg strip of the classical sine wave pattern. Right? You see this is a classical sine wave pattern, what you see in case of very severe hyperkalemia. Right? So you don't have the P wave. The P wave is almost like flat. And you have the wide QRS complex. Right? You have the wide QRS complex. So this is what is called as classical sine wave pattern. And ultimately these individuals with hyperkalemia, what do they have? Right? They have bradyarrhythmias. Right? They have bradyarrhythmias and finally landing the individual into death. Right? Finally landing the individual into death. Okay? So this will be the ECG changes in hyperkalemia. Right? You take one more ECG. Yeah. So this is another ECG which is showing you presence of tall, symmetrical, tented T waves. Okay, you see this? These are your tall, symmetrical, tented T waves. Now, what is the differential diagnosis of your tall T waves? The differential diagnosis of tall T waves is in case of the ST elevation MI. But in ST elevation MI, right, in ST elevation MI, you will have this tall T waves, but you will have broad, right? You will have broad, asymmetrical tall T wave. See, whatever you are seeing here is symmetrical tall T wave. But here in ST elevation MI, you have asymmetrical, broad, tall T waves. Okay. So that is about your the ECG changes in hyperkalemia. So hyperkalemia, ST elevation. Hypokalemia, ST depression. Right? Next. Now, what is that we are discussing? We are trying to discuss what are all the various conditions where you will have ST segment elevation. See the question. 46-year male presents with history of chest pain since 2 hours. ECG is as follows. Right ventricular MI, left bundle branch block, right bundle branch block, the posterior wall MI. See, what is the abnormality you can make out in this? First and foremost, you should be able to make out that there is wide QRS complex. Right, first and foremost, the very important thing is the appearance of the wide QRS complex. And the second important thing is the presence of ST segment elevation. Right? The second important thing is the ST segment elevation. And what is the pattern which is being followed? Right? If you take this pattern which is being followed here, you have a pattern what is called as Williams. So, where is that you have that Williams pattern? You will have this in case of left bundle branch block. Right? You will have that in case of the left bundle branch block. So, you take this as here Williams, that is W-shaped S wave in V1, M-shaped R wave in V6. Right? M-shaped R wave in V6. Okay. So, the same you are able to see here also. That is the presence of the left bundle branch block, you will have the ST segment elevation. So, ST segment elevation, just now we have seen hyperkalemia. Then ST elevation MI, you are completely aware of. Bundle branch blocks where you have the ST segment elevation is in case of left bundle branch block. Okay. Now, what are the conditions where you will have the left bundle branch block? Okay. These are the conditions where you will have the left bundle branch block. So remember the mnemonic A2, D2, H2. A2 is the aortic stenosis and anterior wall MI. D2, that is digoxin toxicity and dilated cardiomyopathy. H2, that is hypertension and as well as the hyperkalemia. So that is what is your A2, D2 and as well as the H2. These are the causes of the left bundle branch block. Okay. Next. Now the one important point that you should know is this is the ECG of the left bundle branch block, right? Now the point you need to understand is if it is a new onset left bundle branch block, that means you have seen the previous ECGs of the patient, there was no left bundle branch block. Now he presented to you with the history of chest pain and ECG is showing left bundle branch block. New onset LBBB, that can be considered as an equivalent to myocardial infarction. Right? That can be considered equivalent to myocardial infarction. So that is what is the ST segment elevation in the left bundle branch block. Okay. Next. Now the other important point is the shape of the ST segment elevation. If the ST segment elevation, if it is convex upwards, that is called Pardee sign. And where do you see this Pardee sign? That is seen in case of MI, myocardial infarction. Whereas if you have that ST segment elevation in the form of concave upwards, okay, right, concave upwards ST segment elevation you are having, then you will see that in case of acute pericarditis. I will show you this respective ECGs as well. Okay. Now, the next important question you see, a 72-year male patient presented with history of chest pain since 4 days. And pain is increasing on applying the pressure over the precordium. Right? When you apply the pressure, the pain is increasing. And he came for further evaluation. His ECG is as follows. What is the diagnosis? Anterior wall MI, inferior wall MI, benign early repolarization, lateral wall MI. So the point which is going against your myocardial infarction in this clinical scenario is the pain increasing on applying the minimal pressure over the precordium. In patients with ischemia or ischemic injury, there is no particular entity like increasing in the pain upon applying the pressure over the precordium. So that is not there, right? That is not there. Okay. This ECG is suggestive of benign early repolarization. So even in case of benign early repolarization also, you will have the presence of the ST segment elevation. Right? You can have this ST segment elevation. That is what you will see in case of benign early repolarization. See, in benign early repolarization, it produces widespread ST segment elevation. right? It produces widespread ST segment elevation that may mimic pericarditis or the acute myocardial infarction. And this is a benign condition. It is not a pathological condition. That is the reason why we are using the word benign early repolarization. Now, this benign early repolarization, it is seen in almost 10 to 15% of emergency department patients presenting with chest pain will have this benign early repolarization on their ECGs. So this is a very common diagnostic challenge for the clinicians. Taking that particular ST segment elevation, if you consider it as an MI and take the patient to the angioplasty, you will not have anything in the coronary angiogram. Okay, so how should you differentiate benign early repolarization from your MI? I will tell you now. Okay, and what exactly is the physiological basis for the benign early repolarization? It is poorly understood. Like, we don't know what exactly is the reason. However, it is generally thought to be a normal variant that is not indicative of underlying cardiac disease. So this is considered as a normal variant. Right, this is considered as the normal variant. And this benign early repolarization, it is less common in the age group of 50 years. It is rare in over 70 years. Now, this particular ST segment elevation in benign early repolarization, how to recognize? I said you, there will be widespread ST segment elevation. And this widespread ST segment elevation is prominent in the precordial leads. Right? It is prominent in the precordial leads. Okay, so this is very, very important. And there will be notching or slurring at the J point. Right? So you can, this is your J point. So there can be a notch or slurring, upward slurring at the J point. And the other important point is, these individuals, they will have ST segment elevation, but there is no reciprocal changes. In MI, what will you have? They will have ST segment elevation and there will be reciprocal ST depression. But here, remember, there is no reciprocal ST depression. Right? There is no reciprocal ST depression. So that is very, very important that you need to remember here. And the ST segment elevation, whatever is there here, it will be less than 2 mm. Whereas in MI, in precordial leads, it should be more than 2 mm to call it as the myocardial infarction. But in certain clinical scenarios, the ST segment elevation may go even up to 5 mm, even in benign early repolarization also. But very important, there is no reciprocal ST depression to suggest the ST elevation MI. And the other important point is, in MI, the ST changes, they change over time. Right? They change over time. There will be progression of this particular ST segment elevation over the time. But here, in case of benign early repolarization, there is no progression on serial ECG tracings. Right? So there is no progression in serial ECG tracings. Okay, that's very, very important. Now, what do you understand by this word reciprocal ST depression? I will show you the ECGs of MI now. In benign early repolarization, you will not have reciprocal changes. Whereas, you take in case of this ECG, it is ECG of the anterolateral MI, right? Where you can have the ST segment elevation in the lateral leads and as well as the anterior leads. Reciprocal changes, you take the inferior leads. What is that you are noticing in the inferior leads? There is presence of a minimal ST depression, right? So this ST depression in the reciprocal leads you will not observe in benign early repolarization. So that is very important in the benign early repolarization. And I have said you that in benign early repolarization, the serial ECGs will remain normal. But you take in MI, how will be the changes? I will tell you. In MI, you will have the following changes. The earliest change, right? The earliest change is the presence of tall T wave, right? Appearance of the tall T wave is the earliest change, where the individual will have a giant positive T wave. Then followed by that, they will have the ST segment elevation. Then there will be appearance of the Q wave. Then there will be T wave inversion along with the Q wave. And subsequently, there is loss of your R wave, right? And ultimately, these individuals, they will have return of the T wave to normal, but persistence of the Q wave will be there. This will be the ECG changes, serial ECG changes in MI. But this serial ECG changes, whatever you are seeing in MI, you will not see that in case of the benign early repolarization. So, to summarize benign early repolarization, remember, benign early repolarization, it produces widespread ST segment elevation that may mimic acute MI. It is seen in almost 10 to 15% of emergency department patient. And what exactly is the physiological basis is not known. And this benign early repolarization, it is thought to be a normal variant. It does not indicate any underlying cardiac disease. And how to recognize the benign early repolarization? You will have that concave ST elevation in the precordial leads predominantly. And you will have notching or slurring at the J point and prominent slight asymmetrical T waves that are concordant with the QRS complex will be there. That means the same direction. And the degree of ST elevation, it is modest in comparison to that of the degree of ST elevation in MI. In case of benign early repolarization, the ST elevation is less than 2 mm. Whereas in ST elevation MI, it will be more than 2 mm or more than 2.5 mm in the precordial leads. And the other important point is, there is no reciprocal ST depression and the ST changes, they are relatively stable over the time. There will be no STT changes in the serial ECGs in case of benign early repolarization. And this is definitely a challenge for the treating clinicians. Okay. You see the next ECG, 68-year-old male presented with chest pain since 2 hours. Patient was taken to the primary PCI and the ECG was done before the patient being taken to the primary PCI. And this is the ECG of the patient. Coronary angiogram shows the blockade in which vessels? Right coronary artery and left circumflex, left anterior descending artery and left circumflex, only left anterior descending artery, only left circumflex artery. So, this is the ECG what I have shown you previously also. This is nothing but your anterolateral MI. Right, this is nothing but your anterolateral MI. So, in anterolateral MI, the vessels that are being blocked are the left anterior descending artery and as well as the left circumflex artery. So, anterolateral MI or MI is another condition where you will have the ST segment elevation. So, until now what all we have discussed? Electrolyte abnormalities like hyperkalemia, left bundle branch block, benign early repolarization, ST elevation MI. Okay, next, you see the next question. The question is, 52-year female patient presents with the chest pain since 1 hour. What is the best management in this patient? Only DAPT, that is dual antiplatelet therapy, Thrombolysis, TLT stands for thrombolysis with streptokinase or altiplase or retiplase or tenecteplase. Primary PCI and statins. So, what is the best management in this patient? So, what is that you are seeing in the ECG? In the ECG, you are able to make out that ST segment elevation is there in the inferior leads. Right? ST segment elevation is there in the inferior leads, and you have reciprocal changes in the anterior leads. That is, ST depression is there in the anterior leads. Okay. Now, the point here is you have the ST segment elevation where mainly in the inferior leads. But if you take that particular ST segment elevation in this clinical scenario, the ST segment elevation in lead 3, it is more compared to that of lead 2. This is suggestive of right ventricular myocardial infarction. If ST elevation is more in lead 2 than lead 3, inferior wall Mi. But if ST elevation is more in lead 3 than lead 2, that is your right ventricular Mi. So this is a case of the RV Mi. And RV Mi, right? Why is that due to? That is due to blockade in the right coronary artery. So what is the immediate management that you need to do in this patient? The immediate best management is the primary PCI. Because the patient is also presented to you with a history of chest pain since only 1 hour. So immediately you have to open the vessel, or with the help of primary PCI, you will have a complete revascularization. With thrombolysis, you cannot have or you cannot guarantee the complete revascularization. But with the help of the primary PCI, you can guarantee a complete revascularization. Right. So before going on to the next question, let me show you a series of the Ecg strips. So what is this particular Ecg strips showing you is, in a patient with the inferior infarction, right, I have shown you a Ecg strips. Subsequently, after 1 hour of onset of pain, how will be the Ecg changes? After 6 hours, what will be the Ecg changes? And after 24 hours, like what will be the Ecg changes? So that is what this particular Ecg strips are showing. See, what is the important point I want to tell you from this particular series of the Ecg strips is that even though the individual has infarction, death of the myocardium, right? This is inferior infarction. But you take lead 2, lead 3 and AVF. How is your ST segment? ST segment is absolutely normal. And do you find any abnormalities in your 1 hour onset of chest pain Ecg strip? More or less normal Ecg. Whereas, subsequently, if you see the same patient after the 6 hours of onset of pain, you can make out the ST segment elevation in the inferior leads. That is 2-3 AVF. And after 24 hours of the onset of pain, you have the absence of the R wave and the appearance of the Q wave. So, what I want to tell you from this particular series of the Ecg strips is that even though the patient might have had an MI, the ECG may be normal in the early hours or in early minutes of the onset of chest pain. So, what is the precaution you have to take? Because the ECG is normal, don't send off the patient telling that it is like some gastric pain, it is some like muscle pain. Don't send him off like that. What you have to do this patient is, you have to take a minimum of 3 serial ECGs. Right? Every 45 minutes, you repeat the ECG. And the serial ECGs can pick up the abnormality if there is the presence of the underlying infarction. Right? If there is presence of the underlying infarction. Okay? Right. Then followed by that, you see next clinical question. A 67-year-old male presented to the ENT department. Since complaining that pain, when he presented at around 2 p.m. he has presented. Complaining of left ear pain since morning. troponin was done, right? The ENT doctor was little clever, right? He has examined the ear and he asked the risk factors. He is a 67-year-old male and he was diabetic, hypertensive, smoker, and family history is also there. So that ENT doctor was clever, and what he has done, he has asked the patient to get an ECG and as well as the troponin. The troponins, whenever it was done, the troponin was positive. And ECG is as follows. Now, what is the treatment what you will give in this patient? Right? What is the treatment what you will give in this patient? So, troponin being positive with left ear pain, you have to consider there is something underlying fishy going on. Now, you take the ECG, STT changes in the precordial leads, that is V2, V3, V4, V5. The STT changes, you don't have a normal STT in the precordial leads, right? You don't have normal STT in the precordial leads. Okay, so troponin being positive with non-specific STT changes, you have to consider this patient to be having non-ST elevation MI. So, in ST elevation MI, serial ECGs will show you a very good ST segment elevation. No doubt it's a MI. But a challenge comes whenever you are having non-specific STT changes. With the background of troponin being positive, we consider this as non-ST elevation MI. Now in non-ST elevation MI, what is the treatment? Primary PCI is not indicated in non-ST elevation MI. Thrombolysis is not indicated in case of non-ST elevation MI. Then how do you treat non-ST elevation MI? With the help of the anticoagulants. Right? With the help of anticoagulants, we treat this particular non-ST segment elevation MI. So, if you describe this ECG, right, the same ECG, the individual is in sinus rhythm, right? And if you take the heart rate, it is around 62 per minute, right? And they have the normal axis, right? They have normal axis, both lead 1 and lead 2, you can see positive QRS complex. And you have normal QRS complexes in all the leads. But you have inverted T waves in V2 to V4 and you have a biphasic T waves in V2 to V5. So this is what is your non-specific STT changes with a background history of chest pain or your left ear pain. Now why do you have this left ear pain in this patient? Let me tell you, many of the patients with MI we have seen presenting to the ENT department, presenting to the dental department. So they have gone with the history of pain within the tooth. There is toothache. Oral cavity examination was absolutely normal by the dentist. ECG done, ECG was showing ST segment elevation. Okay, so this pain of your MI, it is referred to most of the time to your left arm, or it is referred to your neck, jaw, and even it can refer to the left ear as well. So that is what you will see, the referred pain in case of myocardial infarction. Now, following that, let me discuss one more clinical entity where you have the presence of the ST segment elevation. Right, you see this ECG, what will be the immediate management that you will do in this patient? This ECG, it is showing the ST segment elevation. Where all you are having ST segment elevation? In the precordial leads, that is from V1 to V4, you can make out the ST segment elevation. And ST segment elevation is also seen in later leads, that is 1 AVL, V5 and V6. Right, 1 AVL, V5 and as well as V6. Okay. So, the point here that you need to understand is, this is a patient with an acute anterolateral MI. This patient, they require urgent reperfusion. Right, urgent reperfusion. Either you do that particular reperfusion with the help of your thrombolysis or with the help of the primary PCI. Now, you see one more ECG. So, if you take this ECG, what is the abnormalities related to your ST segment you are able to make out? That is, ST segment elevation is there in lead 2, ST segment elevation is there in lead 3, and ST segment elevation is there in the AVF as well. And you are also having reciprocal changes in the lateral leads. But if you take the ST segment elevation, you closely observe there, you are having the ST segment elevation in 2-3 AVF. I do definitely accept that. But the ST segment elevation is more in lead 3 than lead 2. So what is this ECG suggestive of? This particular ECG, it is suggestive of right ventricular MI. This particular ECG, it is suggestive of right ventricular MI. So that is about the abnormalities related to your ST segment in this particular ECG. We will see the next important clinical question. 58-year male patient presented with history of the epigastric discomfort. By seeing the ECG, patient was taken for an emergency PCA. What does the coronary angiogram shows? The options are the block in the left anterior descending artery, block in the left circumflex, block in the right coronary artery, block in the left main coronary artery. See, what is that you are seeing in this patient? You are able to make out that there is very minimal ST segment elevation in the inferior leads. But along with that, you are also able to make out the flat ST segment depression. Right? Flat ST segment depression from V1 to V3. So you will have that in case of the posterior wall MI. Right? So this is the ECG of the posterior wall MI. And in posterior wall MI, what is that you will have? The Ecg changes. You will have a flat ST segment depression from V1 to V3. And there is also dominant R wave, right? You see this is your dominant R wave from V1 to V3. Normally, you don't have that particular dominant R wave from V1 to V3. So you have the presence of the dominant R wave from V1 to V3 in case of posterior wall MI. And whenever you get the ECG like this, what you need to do? You need to replace the precordial leads. How will you replace the precordial leads? This is how you have to replace the precordial leads. That V1, V2, V3, you have to take it off. Place them in V4, V5, V6. V4, V5, V6, you take it off. Place them in the V7, V8, V9 position. And once you place the leads in this position and take the ECG in a patient with a posterior wall MI, this will be the ECG. In this, you will see ST segment elevation in V7, V8 and as well as V9. So what is the abnormality of the ST segment? What we are discussing in this? The presence of ST segment elevation in V7, V8, V9 tells you posterior wall MI. Right? Tells you the presence of the posterior wall MI. Okay. So this is about the ECG changes in posterior wall MI. Next. Now you see the next question. What is the expected complication in this patient? Aortic regurgitation, complete heart block, atrial septal defect, atrial fibrillation. So again, you see this ECG and diagnose what is there and then make out what is the expected complication. So ST segment elevation is there in lead 2, ST segment elevation is there in lead 3 and as well as the AVF. And you have reciprocal changes in lead 1 and as well as AVL and in the V6 as well. That is ST segment depression is there as a part of the reciprocal changes. Now, what is this ECG of? This is the ECG of your RVMI. Why? Because in lead 3 ST segment elevation is more than compared to that of lead 2. Now, in RVMI, what is the vessel that will be blocked? In RVMI, the vessel, right, the vessel that will be blocked is the right coronary artery. And this particular right coronary artery, it also supplies the SA node and it also supplies the AV node. And if the right coronary artery is blocked in patients with RVMI, the blood supply to this particular, the SA node and as well as the AV node can get suppressed. Right. So once your AV node is completely blocked, the individual will land up in complete heart block. Right. The individual will land up in complete heart block. So whenever you are suspecting RVMI, what is that you need to do? What you have to do is, you need to take out the leads which you have placed on the left side and place them over the right side. Right? Place them over the right side. Right? Let me show you that. So this is the placement of the leads on the right side. Right? This is the placement of the leads on the right side. Now, in a suspicious case of RVMI, by placing the leads on the right side in the following pattern, now you take the ECG. Once you take the ECG in lead V4, you have the ST segment elevation. Okay, so you see here V4R, right? You have the presence of the ST segment elevation in V4R, V2, V3 and as well as V1. So posterior wall MI, you have to place the leads at V7, V8, V9. Right ventricular MI, you place the leads on the right side. And if there is ST segment elevation in your right sided leads, because your V4 becomes right sided lead now. And if there is ST segment elevation in V4, V3, V2, then it becomes the right ventricular MI. Right? Then it becomes right ventricular MI. So the expected complication in this patient is the complete heart block secondary to your AV nodal block. These patients with RVMI or inferior wall MI, they can develop mitral regurgitation but not the aortic regurgitation. And why do you think that they will develop mitral regurgitation? Because of the rupture of the papillary muscles from that particular inferior wall. And once there is rupture of the papillary muscles from that particular inferior wall, the individual can develop the mitral valve prolapse and that will subsequently cause the mitral regurgitation. Alright, next. Now in MI, you will have ST segment elevation in the respective leads, not in all the leads. You see the next question. So the next question is, what is the drug of choice for the patient presented with chest pain and the following ECG? Clopidogrel, atorvastatin, aspirin, streptokinase. Now what is that you are able to make out in this ECG? If you closely observe, there is ST segment elevation in all the leads except your AVR. Right? Except your AVR, the ST segment elevation is there in all the leads. And what is the shape of this ST segment elevation? That is your concave ST segment elevation. Now where do you have this concave ST segment elevation in all the leads? You will have this ST segment elevation in pericarditis. So in pericarditis, you will have concave ST segment elevation. Pericarditis is the inflammation of the pericardium. So what is the treatment that you need to give? The anti-inflammatory drugs. So you can give aspirin in these individuals. Now, in pericarditis, you will not just have only ST segment elevation. The other ECG change like what you will have in case of pericarditis is, these individuals, they will also have the PR segment depression. Right? So if you closely observe, there is also PR segment depression in all the leads. Right? PR segment depression will be there in all the leads. Okay. So in pericarditis, you have concave ST elevation in all the leads and PR segment depression in all the leads except your AVR. Right? Except your AVR. In AVR, you will have ST depression and PR segment elevation. That is exactly opposite to that of the other leads. That is what you will see in case of the pericarditis. Now, you see the next question. Vasospastic angina most commonly presents as. See, what I want to tell you here is regarding the vasospastic angina. Vasospastic angina, it is also called Printzmetal angina. And we have three forms of angina. Stable angina, unstable angina and as well as Printzmetal angina. Among all these three forms of angina, the only type of angina where you have the ST segment elevation, That is your vasospastic angina. Right, that is in your vasospastic angina. So vasospastic angina, you have the ST segment elevation. But most commonly it presents as, now you consider this is your A, consider this is your B, C and then D. You can have multiple choice questions in the following manner also. He will give you 4 ECGs and I'll ask you, tell me like which particular clinical condition is suggestive of MI, which particular clinical condition is suggestive of vasospastic angina. So now we will try to trace out or dissect each and every ECG here. Now you take the first ECG. You are having the ST segment elevation in the anterolateral leads. So this is suggestive of the anterolateral ST elevation MI, right? And one point what you need to remember is, in vasospastic angina there will be transient coronary vasospasm, but this particular transient coronary vasospasm is mostly seen in the right coronary artery. Right, this transient coronary vasospasm is mostly seen in the right coronary artery. That is very, very important point that you need to remember. So, if there is transient coronary vasospasm in the right coronary artery, where you have ST segment elevation mostly in your vasospastic angina, that is in your inferior leads. So, you see here now, lead 2, right, and lead 3 and the AVF. You are having the ST segment elevation. And you take the other ECGs. The other ECG, even your ECG C also, you are having the ST segment elevation in the lateral leads and as well as the anterior leads. This is also suggestive of your anterolateral MI. And you take ECG D, you are having ST segment depression in lead V1 to V3 and dominant R wave in V1 to V3. This is suggestive of the posterior wall Mi. So what is the answer now? This is the ECG most commonly suggestive of vasospastic angina. Why? Because in vasospastic angina, the ST segment elevation is predominantly in the inferior leads due to transient coronary vasospasm of right coronary artery most commonly. So that is the reason why the answer B, the option B is the answer to this particular ECG. So what I want to tell you, even in Printzmetal angina, you will have the ST segment elevation. So the next question related to the abnormalities of the ST segment are, if you see this question, the treatment of choice for this condition: cardiac resynchronization therapy, implantable cardiac defibrillator, left ventricular assist device, intra-aortic balloon pump. So if you take this particular ECG, what is the abnormalities? We will directly look onto the ST segment because we are discussing the abnormalities of the ST segment. So if you see here, you have a code ST segment in lead V1 and as well as lead V2. Right, and except for that, you don't have any other abnormalities of ST segment in other leads except for few ST depressions in some of the leads. Now, the presence of the code ST segment elevation in lead V1 and V2, that is what is suggestive of, right, that is what is suggestive of Brugada syndrome. Okay. Now this particular Brugada syndrome, it is a sodium channel defect. Now these individuals, they will have the history of sudden cardiac death. Right, that will be the most common presentation. Or the other form of presentation of this particular Brugada syndrome is the syncopal attack. Right, syncopal attack is another very important clinical history in these patients with the Brugada syndrome. But the other way of presentation is they will directly present with a sudden cardiac death. And what is the treatment of choice for this condition? The treatment of choice with these in this condition is the implantable cardioverter defibrillator. So what is the cause of death in these individuals? These patients with the Brugada syndrome, right, they will die due to the arrhythmias. Right, they will die due to arrhythmias. Now, in order to prevent this particular death due to arrhythmias, we need to place the implantable cardiac defibrillator in these patients. So, what I want to tell you here is ST segment elevation is also seen in the Brugada syndrome. Now, after having discussed about this particular Brugada syndrome, okay, now let me show you the another types of ECGs, or like the types of Brugada syndrome. If you see that here, so we have three types of the Brugada syndrome, that is type 1, 2 and as well as third type of Brugada syndrome. Now what is the difference in between all these three types of Brugada syndrome? You will have ST segment elevation in type 1, type 2, type 3. Whereas you take in case of type 1 Brugada syndrome, there will be coved ST segment elevation. So you see here, this we call it as coved ST segment elevation with T wave inversion. Right, coved ST segment elevation and inverted T wave both in V1 and as well as V2. That is what you will have in case of type 1 Brugada syndrome. Whereas if you take type 2 Brugada syndrome, right, type 2 pattern with saddleback ST segment elevation, right, if you see this is your saddleback ST segment elevation. And how much will be this particular ST segment elevation? This will be more than 1 mm. That is in case of type 2 Brugada syndrome. Whereas in case of type 3 Brugada syndrome, there will be also ST segment elevation, but you will not have that particular saddleback shape like what you will see in the type 2. So there will be ST segment elevation and that will be of more than 1 mm. So this will be of type 3. So to summarize, in type 1 you will have coved ST segment elevation with T wave inversion in V1 and V2. Whereas in type 2 you will have saddleback shaped ST segment elevation of more than 1 mm. Whereas type 3 you will have ST segment elevation, but that will be of more than 1 mm. So that will be the various types of Brugada syndrome, and the presentation of the Brugada syndrome is most commonly with the sudden cardiac death, and it is a sodium channel defect, and the treatment of choice in these individuals will be implantable cardioverter defibrillator. And the antiarrhythmic drugs that can be given is, you can give quinidine. Quinidine is the medical management that can be helpful, but ultimately these individuals, they will be requiring implantable cardioverter defibrillator. So after having discussed about the various conditions where you will have the ST segment elevation, now let me discuss the conditions where you will have the ST segment depression. So to summarize all the conditions whichever will be causing the ST segment elevation. So what was the mnemonic like I have discussed? The mnemonic what I have discussed is elevation AB. What does this E stands for? The word E stands for electrolyte abnormality, that is hyperkalemia. L is your left bundle branch block. E is your early repolarization variant or benign early repolarization, right? And the word V is your ventricular aneurysm. T is your trauma, that is pericardiocentesis. I is your ischemic injury, that is myocardial ischemia. The word O is your Osborne wave, right? You will see that in case of hypothermia. I'll be showing that ECG of hypothermia as well. And in the mnemonic elevation, N, non-occlusive vasospasm, that is Printzmetal angina. Then A, B. So A stands for acute pericarditis, B stands for the Brugada syndrome. So these are all the conditions where you will have the ST segment elevation. Now, if you take the ST segment depression, the shape of this particular ST segment depression or the pattern of the ST segment depression, if you see, it can be upsloping ST segment depression, or it can be downsloping ST segment depression. You see here, there is ST segment depression, but it is of downsloping ST segment depression, or it can be just a plain horizontal ST segment depression. So these are all the various patterns of the ST segment depression. Now this particular ST segment depression, either it is horizontal or downsloping. The ST segment depression is considered significant if it is more than or equal to 0.5 mm at J point, and that should be in more than or equal to 2 contiguous leads, and that will indicate the presence of the myocardial ischemia, right? That will indicate the presence of myocardial ischemia. Now whenever there is an ST segment depression, what will be the reciprocal changes? The reciprocal changes will be the ST segment elevation, right? So in one lead, if you have ST segment depression, the reciprocal changes will be the ST segment elevation exactly to the opposite side of the infarction. Now, let me tell you all the conditions where you will have ST segment depression. So, in this slide, what is the very important point? When do you call significant ST depression? If the ST depression is more than or equal to 0.5 mm at the J point. Now, you take the causes of the ST segment depression. You take ST elevation MI, you have ST elevation. Whereas, you take the other forms of acute coronary syndrome. Acute coronary syndrome, we have three entities. One is ST elevation MI, second one is non-ST elevation MI, and the third one is unstable angina in acute coronary syndrome. Now, if you take the other two forms of the acute coronary syndrome apart from ST elevation MI, that is non-ST elevation MI and as well as unstable angina, you will have ST segment depression. So, if you see this slide here, non-ST elevation MI and as well as unstable angina, you have the ST segment depression. And the very important is in case of posterior wall MI. In posterior wall MI, you will have the ST segment depression in from lead V1 to V3. And you will have a dominant R wave in V1, V2, V3. That is what you will see in case of the posterior wall MI. So in posterior wall MI, ST depression, that too, it will be a horizontal ST depression from V1 to V3, right? I'll be showing that ECG as well. Next is the digoxin effect. See, in patients with a congestive heart failure and in patients with the atrial fibrillation, we give this particular digoxin. And how will you assess that the individual has developed that particular digoxin effect? That is by your ST depression. Okay, you can see here, right? So this is nothing but your digoxin effect or digitalis effect. So this particular digoxin effect or digitalis effect on the ECG, right? This is given by an important sign that is called as inverted moustache sign, right? That is nothing but the inverted moustache sign. Okay, so where you have the sagging morphology, right? So that we call it as Salvador Dali's moustache. Right. Then followed by that, the hypokalemia is another condition where you have ST segment depression. I have said you, hyperkalemia, ST segment elevation, hypokalemia, ST segment depression. Okay. And the other thing is, in case of chronic stable angina, where the TMT is positive. So these are all the conditions for the ST segment depression. Now we will take up some questions as well parallelly. Right. You see this question. ECG shows the drug effect of digoxin effect, beta blocker effect, norepinephrine excess, AC inhibitor excess. So if you observe closely the ECG, right, because we are discussing the abnormalities of the ST segment, I will directly move on to the ST segment itself. So you take this lead 2, right? First of all, what is this ECG suggestive of? This ECG, it is having irregular rhythm. Right, it is having an irregular rhythm. Okay, that is one point. And if you take the ST segment here, right, so how is the ST segment? The ST segment is depressed. So what is the condition where you can have this irregular rhythm? That is in case of the atrial fibrillation, right? That is in case of the atrial fibrillation. And this patient with the atrial fibrillation has been started the digoxin. And when you start this particular digoxin effect, there will be ST segment depression in a form of an inverted moustache sign. Okay, so this, we have another terminology, right? If you see this, this is also called hockey stick appearance. Right, this is also called the hockey stick appearance in the ECG. So that is what is nothing but your digoxin effect. Okay, right. Now, after having discussed about the ECG showing the digoxin effect, let me show you one more ECG corresponding to your ST depression, and then let me tell you the diagnosis as well parallelly. So if you see this ECG and directly concentrate on the ST segment, so what is that you can observe here is you have the ST segment depression in lead V2 and as well as V3, and you also have in V4 and as well as V5. Yeah, so these are the leads where you have the ST segment depression in this particular ECG, and that is an upsloping ST segment depression. Now, the history is not given in this ECG, then what all the things you can suspect in this patient? See, if this patient presents to me with the history of chest pain, then I will suspect an ischemic heart disease. Right? I will suspect the ischemic heart disease. Now, within the ischemic heart disease, what is the type of ischemic heart disease you will consider in this ECG patient? So, because the ST segment depression is there, I will consider either unstable angina, right? Or I can also consider non-ST elevation MI. Right? I can also consider non-ST elevation MI. Okay, so these are the two things what I can consider if it is a background history of an ischemic heart disease. So then how will you differentiate these two? Based on ECG, I cannot differentiate unstable angina and as well as non-ST elevation MI, because in both of them there is ST segment depression. How I will be able to differentiate is by the cardiac biomarkers. In case of unstable angina, the cardiac biomarkers, they will be negative. Whereas in case of non-ST elevation MI, the cardiac biomarkers will be positive. So based on the cardiac biomarkers, I will be able to differentiate the unstable angina and as well as the non-ST elevation MI. Right? So what I mean to say from this ECG? ST segment depression is seen in case of non-ST elevation MI and as well as unstable angina. Now let me show you one more ECG. So if you see this ECG, what is that you are observing? Directly concentrate on the ST segment. See, in this ECG, you can observe that there is presence of ST segment elevation in almost all the leads. Right? In almost all the leads, you have the ST segment elevation. Okay. And how is the shape of that particular ST segment elevation? It is concave ST segment elevation. Right? It is concave ST segment elevation in all the leads diffusely. But what am I concerned when I am discussing the topic of ST depression? Why did this question of ST segment elevation has come? You take in lead AVR. In lead AVR, you are having the ST segment depression. Right? In lead AVR, you have ST segment depression. So now what is that clinical condition where you have diffuse ST segment elevation in all the leads except for ST segment depression in AVR? You will see this in patients with the acute pericarditis. Right? You will see this in a clinical scenario of the acute pericarditis. So in acute pericarditis, there they can have this particular diffuse ST segment elevation and ST depression in lead AVR. Right? In lead AVR. Okay. Now in case of acute pericarditis, not only ST segment elevation diffusely, you will also have the PR segment depression. Right? You also have the PR segment depression. Right. So PR segment depression is present in all the leads except again the AVR. In AVR, you have the PR segment elevation. Okay. So whatever you are seeing in the other leads, exactly reciprocal or opposite, you will have in the AVR. Okay. So this is about an ECG where you have ST segment depression selectively in AVR, that is in patients with the acute pericarditis. Now you see the next important ECG. Right. So if you are seeing this ECG, what is that you are observing? Okay, you see the clinical scenario. 63-year male had hypoxic ischemic encephalopathy. Right? HIE stands for hypoxic ischemic encephalopathy. And he was managed at 34 degrees centigrade. See, once the patient develops this hypoxic ischemic encephalopathy, in order to reduce the basal metabolic rate of the body, right, we will induce hypothermia in the individual. Right? We will induce hypothermia in the individual. Right? So that the metabolic demand of the body should be reduced. So that is the reason why we will induce hypothermia. So he was managed at 34 degrees centigrade and routine ECG is being done, right? It is showing as follows. Okay, see what is that you are seeing or you are observing is, you are observing the presence of the ST segment elevation, right? You are observing the presence of ST segment elevation. And along with the ST segment elevation, there is one more abnormal wave what you have to observe. And this is that particular abnormal wave. Okay, so exactly at the J point, right? Exactly at the J point, you are having a blip. And this blip is nothing but your Osborne wave. Right? This particular blip is nothing but the Osborne wave. So Osborne wave, where do you see? You will see that in patients with the hypothermia. Right? You will see that in patients with the hypothermia. This is a very, very important point that you need to remember regarding the hypothermia. In hypothermia, along with this Osborne wave, what is that you will have? You will have ST segment elevation. Right? You will have ST segment elevation. So, in the mnemonic, I have said you elevation, T-I-O-N. O is your Osborne wave. Where do you see that Osborne wave? That is in patients with the hypothermia. Right? So, this is the ECG of ST segment elevation but not ST depression. Now, following that, let me show you some more ECGs related to your ST segment depression and I'll tell you the diagnosis as well. Okay? Right. So, if you take this particular ECG here, directly concentrate on the ST segment. What is that you are able to make out? You are able to make out the ST segment depression in V1, V2 and as well as V3. And it is a horizontal ST segment depression. Right? It is a horizontal ST segment depression from V1 to V3. And along with that, you also observe lead 2-3 AVF in this patient. There is mild ST elevation in 2-3 AVF. So in 2-3 AVF, if there is ST elevation, what is that suggestive of? Right, with the background history of chest pain, you have to think of the inferior wall MI. And in this patient with the inferior wall MI, you are having the ST segment depression from lead V1 to V3. What is this suggestive of? This is suggestive of the posterior wall MI. Right? So in posterior wall MI, what will be the ECG finding? They will have the horizontal ST segment depression and along with that you have the presence of dominant R wave in V1, V2 and V3. Right? So you will have a dominant R wave in V1, V2 and as well as V3. Okay. Now what I want to tell you here is, why are you having a patient with inferior wall MI with the posterior wall MI? The reason is that inferior wall is also supplied by your right coronary artery, majority in most of the individuals. And posterior wall, that is also supplied by your right coronary artery. So, in patients with the inferior wall MI, they can have the association of the posterior wall MI. But in certain clinical scenarios, you will have only posterior wall MI. In certain clinical scenarios, you have only posterior wall MI, right? Inferior wall MI is not there. And that particular ECGs, they are called as true posterior wall MI. Right? That particular ECGs, they are called as true posterior wall MI. Okay? So, true posterior wall MI means they will have the ST segment depression V1 to V3, horizontal ST segment depression and dominant R wave from V1 to V3. That's all. In true posterior wall MI, you will not have the changes of the inferior wall MI. Right? So, this is about the another condition where you will have the ST segment depression. Okay? Next. The other point is the ST segment depression can also be seen in case of the hypertrophy of the ventricle. Right? For example, you take in case of left ventricular hypertrophy. What will happen, like where all you can have left ventricular hypertrophy? Wherever there is increased afterload on the left ventricle. Like for example, hypertension, increased afterload on the left ventricle, aortic stenosis, hypertrophic obstructive cardiomyopathy. In all these conditions, there will be left ventricular hypertrophy. And whenever there is left ventricular hypertrophy, what will happen to your myocardial oxygen demand? The demand is more, right? So they will have increased demand but less supply. That will lead to subendocardial ischemia, right? That will lead to subendocardial ischemia. And because of this subendocardial ischemia, the individual can have the ST segment depression. So this, we call it as the strain pattern, right? The ST segment depression in left ventricular hypertrophy, we call it as the strain pattern. And you will see this particular strain pattern mainly in the precordial leads, okay? And that too, the later leads, that is V4, V5 and as well as V6 in left ventricular hypertrophy, okay? Right. And the other conditions where you can have the ST segment depression is severe anemia and as well as cocaine overdosage. So this anemia, what will happen? There will be less oxyhemoglobin, there will be reduced supply, that will lead to a subendocardial ischemia. Right, whenever there is subendocardial ischemia, they can have this particular ST segment depression. Okay, now after that, I initially, when I was discussing the ST segment depression, I have shown you a ECG of the digoxin effect, right? Now, what all will be the other features of the digoxin effect? Okay, you see this ECG? So, this is the ECG of the digoxin effect, right? So, a patient with the atrial fibrillation on digoxin, and if you see that particular ST segment, that is depressed. So this we call it as inverted mustache sign, or we call it as the hockey stick appearance of the ST segment. Okay. Now what are the other features of the digoxin effect? Digoxin, what it will do to the ventricle, it will increase the contractility of the ventricle. So thereby, along with the ST segment, there will be also QT interval, it becomes short. Right, the QT interval, it shortens, and the PR interval prolongation will be there. I will explain you each and everything why it will occur. So if you take the PR interval, there will be prolongation of the PR interval. Now why there will be prolongation of the PR interval? Why? Because digoxin, it will increase the refractory period at the level of the AV node. Right? This digoxin will increase the refractory period at the level of the AV node. Now, because it increases the refractory period at the level of the AV node, the PR interval will be prolonged. Why? Because what is PR interval? PR interval is nothing but the time taken for the impulse to move from SA node to the AV node and through the AV node. And digoxin is increasing the refractory period at the level of the AV node. So it takes more time for the impulse to pass through that particular AV node. So thereby what will happen to your PR interval? There will be prolongation of the PR interval. Now, and what will happen to the ST segment? There will be ST segment depression. And what will happen to the QT interval? The QT interval, it becomes shortened. Right? So this is about the digoxin effect. Right? This is about the digoxin effect. So that classical sign of hockey stick sign, right, that hockey stick sign of your ST segment, you see that particular ST segment, it is depressed. So that classical hockey stick sign on ECG is suggestive of the digoxin effect. Okay. Now, after having discussed about the digoxin effect, what will be the features of digoxin toxicity? Digoxin effect is different. Digoxin toxicity is different. Digoxin effect, you have just only the ST segment depression. But I'll show you one more ECG here. This is the ECG of digoxin toxicity. So in digoxin toxicity, what is that you are observing? This is a normal complex and this is an abnormal complex. Right? This is a normal and this is abnormal. This is normal and this is abnormal complex. Okay. You can see that there is a wide QRS complex there. You see here, completely wide QRS complex. Right. Now what is this suggestive of? This wide QRS complex is suggestive of a ventricular rhythm, right? And this is the ECG of the ventricular bigeminy. Right, this is the ECG of the ventricular bigeminy. So, the most common arrhythmia you will see in digoxin toxicity is ventricular bigeminy. Right, the most common arrhythmia you see in the digoxin toxicity is your ventricular bigeminy. Okay. Now you see one more ECG of the digoxin toxicity. Right. So this is another example of the digoxin toxicity. So wherein you are able to make out, see, this is your normal QRS complex. And this is a wide QRS complex. Okay. So normal, wide, normal and wide, normal and wide. Okay. So alternating complexes, they are the abnormal QRS complexes. Right? The alternating complexes, they are the abnormal QRS complexes. So which is suggestive of the ventricular bigeminy. So if you see another example of the digoxin toxicity, what is that you are observing? You are observing that more or less all the complexes, they are broad QRS complexes. Right? You see all of them, they are the broad QRS complexes. But if you are seeing this particular, the QRS complexes, they are broad. It is definitely, I will call it as the broad complex tachycardia. Right, definitely this we call it as the broad complex tachycardia. Right, see, in these individuals or in this particular patient, there is a broad complex tachycardia with frontal plane axis that alternates by 180 degrees with each successive beat. Okay, so you see this particular complex, it is a positive complex, and you see the alternating complex, it is a negative complex, and this positive and negative complexes, they are alternating by 180 degrees with each successive beat. Right, that alternates by 180 degrees with each successive beat. So this I will call it as bidirectional VT. Right, this I call it as the bidirectional VT. Okay, right. So one of the most common arrhythmia in case of digoxin toxicity is ventricular bigeminy. And the other important arrhythmia like that can be seen in patients with digoxin toxicity is the VT. Right, and the individual can have a bidirectional VT. So after the digoxin effect, I wanted to just show you some of the ECGs of digoxin toxicity as well. So I want to tell you the difference between digoxin effect and as well as digoxin toxicity. Alright? Right. So if you take the other ECG, what is that you are observing in this ECG? Directly concentrate on the ST segment. ST segment is depressed. But apart from the ST segment, right, you are seeing some other abnormal wave here. And what is this abnormal wave? This is your U wave. Right, this is your U wave. So how can you tell that? Because this is the T wave which is inverted, and the subsequent positive wave again is a U wave, and this is your P wave. So where will you have this particular U wave and ST segment depression? This is the ECG seen in patients with the hypokalemia. Right, this is the ECG seen in patients with the hypokalemia. So in hypokalemia, what are the ECG changes you will observe? You will observe the presence or appearance of the U wave. The T wave, it becomes flattened and it gets inverted. ST segment, it will be depressed. And the other important ECG change in hypokalemia is subsequently in very severe hypokalemia, they can also have pseudo P pulmonale. That will be the ECG changes in patients with the hypokalemia. So what I want to tell you here is, in hypokalemia also, there is presence of the ST segment depression. Right? So now what are all the conditions where you will have the ST segment depression now? To summarize, number one, the drug effect, that is digoxin effect. Myocardial ischemia, that is unstable angina and as well as non-ST elevation MI. Posterior wall MI, hypokalemia and chronic stable angina, with the TMT being positive. This completes the discussion of the ST segment abnormalities. You should know what are all the conditions where you have ST segment elevation and what are all the conditions where you have ST segment depression. Thank you very much.